We will discuss this concept more in the trauma modules also, that what is a component of damage control resuscitation except, right? So whenever a person has an ongoing hemorrhage and whatever fluids you give, the hemorrhage till you don't stop, it's not going to make any difference. He will bleed out. In fact, if you keep giving IV fluids without stopping the hemorrhage, he may become diluted. There may be a dilutional coagulopathy. So a person in whom the aim is to first stop the hemorrhage, even before you resuscitate, that is called as a damage control resuscitation. Okay, it is called as a damage control resuscitation, where your aim is first I will stop the bleeding, then I will, give him the fluids and all. In the interim, what to do? That is damage control resuscitation. So what do you do in this? You use blood products. You avoid crystalloids because there is a risk of dilutional coagulopathy. Right, there is a risk of dilutional coagulopathy. So give as much of blood and blood products as possible. Limit the use of crystalloids. Do surgery to stop the bleeding as early as possible. That is called damage control surgery. But the blood pressure you don't maintain at a normal level. The blood pressure you maintain little below 90, like something like 80 to 90 systolic, which is acceptable. It should not be very low. It should be acceptably low. That phenomena is called permissive hypotension. Okay, so what you are doing, you're not making him normotensive, because if you make him normotensive, but the hemorrhage is ongoing, the hemorrhage will get more. It will get worse. So in the interim, till you don't stop the hemorrhage, keep the blood pressure just about okay, little below normal. That is called permissive hypotension. So that the brain, kidneys, they are all perfused. Other organs can so far in the meanwhile wait. If you make the BP high, then he will bleed more, right? That is the logic of using damage control resuscitation principles. That is the logic.